what I'm trying to do, often a little bit different to what other teachers are doing, is I want to make this safe. Right? Everything I prescribe needs to be safe. It has to be justified and it has to be safe. It has to be able to, anything you start, you have to be able to finish. And part of making it safe is to understand the limitations of what we can actually do. See, there's no limitation to what we can start, but there is a limitation to how we can finish. And part of the safety aspect of that limitation is to understand the limitation. And there are two sources that are available to you to make difficult things safe. And those two sources have a name. They're called ENT and max-fac surgery. And that's why I brought Perry and Roland into play. Right? Because when you are faced with a complex skeletal problem and you don't have the experience, your correct recommendation is, this is a surgical orthodontic case and we need to consult with a max-fac surgeon. Right? Because that's informed consent, and that's critical when especially you're dealing with an older child. Much, 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 much more critical when you're dealing with a child who's approaching puberty or pubertal. You will face, the majority of the people coming through your door will be pubertal teenagers who need orthodontic surgery, and you will, instead of consulting a max-fac surgeon, you will rack your brain, stare at the ceiling all night long and wonder, how can I save this kid from surgery? And that will be absolutely the worst thing that you could possibly do. 2, most of what we do does not work if the nose doesn't work. And if you don't have that in the very front of your mind, then you'll never deal with the right avenue of sequencing, which is very often a consult with an ear, nose, and throat surgeon first. So let's open up the chat forum to questions that are related to ENT and max-fac surgery, so that we can, get a safety net built around us by people who are here to help us. So if anyone has questions for ENT or max-fac surgery, please post them up on the chat now.
All right, terrific.
All right. In the meantime, we can... oh, here we go.
Okay, so Maria has a question for ENT, which is her question 8.
Let's go to her 8.
Excellent. ENT. So let's read
Maria.
this out.
Maria, you've got Cindy. Yeah, Maria.
No, this is Maria now. It is clear that tonsillectomy and anoidlectomy is needed. What should be the sequence? Operation first, then expansion, expansion first, then operate at the same time, or depends? Most of my plate patients who were sitting on the fence regarding the operation reported significant improvement in sleeping after the expansion, decided to postpone ENT intervention. So one for Perry.
Look, I think that's a perennial concern, and we talked about this last week as well. I think that you have to work out what's absolutely best and have that as your sort of carbon 12, and then work out what is suboptimal after that. So I think there's 2 things to address initially in that. One is, are your inputs going to work well with the airway suboptimal? And B, is your retention of those results going to be able to be maintained? So I think they're 2 fundamental questions that you have to answer. And I think that's
a screening issue and a diagnostic issue. And one of the things that you have to determine is you have to be able to determine what level of medical health compromise they have when they present to you. And if you can figure out what that cutoff with, then sometimes it's a matter of spending some time with someone like Perry to really understand at what point is this a medical emergency. You know, patients don't know what a medical emergency is if it's obstructive airway issues, because it only happens at night when no one's paying attention. You know, we don't know, because unless we're watching our own kids having, you know, episodes at night, we don't know either. Like, you ask your parents, do they stop breathing at night? And they open their mouth to respond to you, but you know they have no idea. They actually have no idea. And they don't know what to say, because they should know, but they don't. So my screening questionnaires, the PSQ and the clinical sleep records, will help you understand that. And when you're uncertain, you know, it's like COVID-19. When uncertain, what should we do? Should we just go on about our normal life, or should we lock down? And my response when it's to do with an airway is, if we're not sure, send it off to Perry and he'll let you know, because he's the expert. If you're sure, then you can make your decision. If the nose works and it's only a mild issue, then expand first. If it's so severe that there's no patency at all, it's a no-brainer, go to Perry. If there's a 15 on the PSQ, go to Perry. But if you're uncertain, on the fence, pick up the phone, send the records to Perry and say, hey, Perry, here are my records, what do you reckon? Don't send the patient to Perry and say, what do you reckon? Pick up the phone and ask Perry, what do you think? So that's my answer. And I think Perry would agree, because you don't want people turning up unqualified, but you equally don't want people put at risk because we don't know any better.
I think that there's clearly a spectrum here, and you go from kids that are mildly congested through to what I remember, one of the most severe cases I've ever seen, where the parents were actually taking it in turns as a vigil by this kid's bedside, wondering whether the kid was going to survive the night because they were so congested. So that's the spectrum that we see. I think also, you know, a lot of what we do in surgery, and I assume it's the same in orthodontic issues, is it's patient expectation. If they want the best possible result, but they're not prepared to have the best airway, then they're diametrically opposing issues here. And I don't think that you can be expected to get a brilliant result if you don't have the airway working in sync with you. And so, yeah, that's a question for the parents. They often ask me what I think about various orthodontic inputs, and I say, I don't think that I'm really qualified to talk about that. Just as I don't think an ENT, just as an orthodontist or a Fascio Max person is qualified to talk about ENT issues. You can have a knowledge about the veracity of that, but not in the specifics. So I just tell them that, you know, we're here to play an instrument in the orchestra, and we're part of a team. And I think it behoves us for everyone to play their role and to do their very best. Now, if they want to accept something that's suboptimal, then they have to be prepared to achieve suboptimal results. And that's not what we're after.
And sometimes you have to be very firm. See, you know, the less experience we have, the more wishy-washy our recommendations. And the more experience we have, the firmer our recommendations can be. And sometimes you know that they're not going to go ahead with the ENT consult, so you look them in the eye and say, I can't help you until you do. When you finish your consult with Perry and they've made his decision and gotten the treatment that you need, then you're welcome to come back into my practice and we can talk about starting.
So my question, Simon, is have you had cases where parents and patients, they elected not to go through recommended surgery and after your treatment, it improved so much that they actually didn't need one.
Sure, that does happen. But, you know,
Hence my question whether sometimes you would go with the treatment because there is a likelihood that it's going to improve. Then, you know, like we said, like we were talking about deviated septum, once you expand that maxilla, it just gives you floor of the nose so much wider that your hole may be bigger and now good enough to nasally breathe and retain.
So you've got to make a decision based on what level of severity you feel the medical compromise is.
Yeah.
If you can make a judgment that says it's within an acceptable range. Now, you know, there's nothing better than using metrics, ways of measuring it. And, you know, use the PSQ, use the sleep clinical record, but equally important, use something like the Snore Lab app so that you can record the level of snoring levels at nighttime, and get the parents to sit and spend 10 minutes in the middle of the night and film their kid on the camera, and then bring it in to Perry and show him, you know, my kid stops breathing X number of times, it's snoring off the chart, what do you reckon, Perry? And Perry will say what? Well, he'll have a metric. He'll have something. That's not a sleep study, but it costs nothing to do that. Right? And then when you sit and you watch a kid stop breathing, your mindset changes to when you're told he needs an operation because his tonsils are big. So you have to get the parents.
I like using metaphors a lot, and you know the metaphor I often give people when it comes to sleep apnea is, you know, if you had your computer that was literally shutting down every few minutes, you'd go berserk and you want it fixed. Well, if that's your airway and it's the most important thing keeping you alive, then I think that's essential. I think that also you need to think about, and this is what I was getting at last week about the nuance of the advice, that it's not just this reflexic advice, that given that you're seeing people at varying times in their development, you need to take that into consideration. So if you've got someone, for instance, that has got significant orthodontic issues and they presented relatively late or later than you would like, then you suddenly got less time to do more significant things. And I think in that situation, you ought to pull out all stops and be more proactive. If, on the other hand, you've got a 6 or a 7-year-old, well, you've got time on your side and you can be preparing to be a bit more observational. And so again, the metaphor I give patients is it's a bit like being in a river, and it's a question of how hard that current is going in the opposite direction. You know, if it's just very, very, very slow, you may accept that. But if it's strong, you're not going to be heading in the direction you want, and you're going to have a suboptimal outcome, which is going to reflect poorly on your ability, and your patients won't be happy. And that's the metric that we don't want. We want, as I said last week, the top left-hand corner, which is the happy patient and the proud practitioner.
And a very quick practical question. If time is not on our side and we're moving quickly, starting expansion by waiting for surgery.
Sorry, can you just repeat that again? Sorry, I missed that.
So if time is crucial and we try to move quickly, starting orthodontic expansion as well as waiting for the surgery, and finally got the time of the surgery and the surgery is done, how long is the patient, does the patient have to stay without the plate after your surgery? Because as you know, with the plates, we're trying to keep them.
I fit them within a week.
Within a week.
Yeah, often the patient comes in 2 or 3 days after and I'm fitting the plate back in again.
Yeah.
Yeah.
There's no contraindication to proceeding with treatment. It's just a comfort thing. It's not like you've got something that is manifestly problematic. It's just a question of comfort. But I mean, again, when we talk about surgery, there's different levels and degrees of. I mean, the most painful thing I inflict on anyone is a tonsillectomy, because it's raw mobile muscle and it's sore. And that's why I talked about last week about all the various treatments that we give in the perioperative period to try and get people through in good shape. But that shouldn't in any way adversely mitigate against what you're doing orthognatically.
Simon, would you put Essex in just to keep teeth stable for that time? Because Essex doesn't go on the palate, so technically shouldn't.
I've never found. I've had lots of kids off for ENT, and then they come back usually within the week of having their surgery, and they're either already wearing the plate or I fit them back in.
Yeah, cool.
Mm-hmm. It's not palatal surgery.
As Simon said, I think there's a small cohort of patients where a prudent dental practitioner will say, I'm not going to proceed with treatment unless you have your airway improved. I mean, it's a small percentage, but you don't want to be in a position where you're set up to fail. You know, you then need to be professional defence and to ensure that your outcomes are good. You know, you're like an artist. You know, you don't want to put suboptimal paintings out there in the marketplace. You want your results to speak for yourself, and you're only going to get that with a good airway.
Great. So I think there's some more questions.
Yeah, let me. There's a question from Cindy Lynn, and then I'll ask Judith and then Mirola. So let's go to Cindy. Hi, Perry. Could you tell us how you manage different types of allergies? For example, use of steroid sprays. Which testing is best for different types of allergy? Which ones should you consider? Which one should consider skin, and which should consider blood testing?
Okay. You know, when I was at school, no one had a peanut allergy, and these days, you know, allergies are widespread. So we've seen an absolute explosion in allergic diatheses. And so again, you've got the kids that have had severe anaphylaxis to various products, and they're already under the care of an allergist. Again, it depends on your degree of suspicion. So if the patient is clinically bad, has got lots of nasal and ocular symptoms, is quite distressed by hay fever, and has got significant congestion in their nose, then I would be wanting those kids to be very, very actively assessed. I mentioned last week that allergists can only do three things. They can give you a spray, they can tell you to avoid something, but you can't avoid life, or they can desensitize you in one way or another. Okay? Now, most of the people that I send to allergists don't get desensitization because they're younger kids, but they're bad enough that I want them fully assessed, and I want them under the umbrella of someone that can activate that sort of treatment when appropriate. Most of them go on a nasal steroid, but you also have to be cognizant that it's not a lolly, and that steroids have adverse effects. They have potential growth inhibitory effects. They have some constitutional neuropsychiatric effects. They can cause local nasal bleeding and crusting. So again, you know, every medicine that we use is either an effective regimen or a poison, depending on the dose and degree. But generally speaking, what I want to do is not be seen unless you've got what I call an absolute indication where you've got a significant airway problem. Most people don't want to rush into surgery. You get the small percentage that say, look, doc, just cut to the chase and fix my child. But most people want to see you as a human being before a doctor, as a surgeon. And I think they want to see that you're trying some things. But also, you know, Simon talked about giving clear directives. I think you also want to say to them, look, we'll try this for a short period of time, because I might have a waiting list anyway, but you want to give some people an idea of the effectiveness of a various treatment. And if you say, look, your child's got massive adenoids, very swollen turbinates, we're going to start you on this nasal steroid spray in the interim, but I don't think it's going to be a major game changer, then you've at least given them an indication of the likely efficacy or otherwise of that treatment. Because that's what they want. They want your experience. They don't want you looking at a list of possible treatments and ticking them off. They want nuance in your advice. So that's how I approach it. If you ask them about RAST versus skin prick testing, well, you got to remember that the RAST test only gives you 5. Well, it also depends on which pathology provider you go to. So there are some that just say allergic or non-allergic, and I never use those providers. And there are some that give you a printout of usually 5 different substrates. So you have cat, dog, dust mite, grasses, and mold. Okay, they're the 5 things. So cat, dog, dust mite, grasses, and mold. But when they do a skin prick testing, they usually have 20 substrates that they're up against. The other thing that you also need to be aware of is that if they're taking a product, say, called Dymista, which has got a steroid and antihistamine in combination, they have to be off that for at least 10 to 12 days because that antihistamine will negate the skin prick testing. Same with oral antihistamines. So they can't be on the antihistamines and get a skin prick testing. So again, it depends on severity. If I think a kid is severely allergic, is going to be a candidate for desensitization, has significant allergies, then those patients, again, you know, we've talked about the multidisciplinary approach. I want those kids to be under the care of an allergist because at the same time, when I do something to their nose, I want the patients to understand that the treatment doesn't stop at me and that there are going to be likely to be other things that need to be considered. And we talked about doing the right thing at the right time. There are much smaller interventions that we can do to their nose that are appropriate for smaller kids. And there are some more aggressive things that we can do to the older kids. But they need to know that their kid is in this spectrum of development. And what I tell them, I tell every patient this, is that I want them to think of me as their ENT custodian and I'll do the right thing at the right time. So I hope that sort of answers your question in a roundabout way.
Thank you, Perry. That's great. Would you say for the younger kids, at what age would you start referring them for allergy testing if it's not considered too early?
Well, as I said, the kids who've got severe anaphylaxis or have got severe food sensitivities, then those kids are often been under a paediatric allergist already. I think that the key is when you can invoke allergy treatments, because up till the last few years, the only way you could desensitize someone was by injection. And I've yet to meet a kid who relishes the thought of having an injection every week. Okay. So in more recent times, there's been the development of what we call sublingual immunotherapy, so known as SLIT, S-L-I-T, sublingual immunotherapy. And in more recent times, again, there is various oral preparations and tablets, especially to dust mite. So again, most of those kids aren't going to be having something like that until they're, getting closer to, 7, 8, 9, 10 or beyond. I've yet to meet a 4-year-old who's been given desensitization treatment regimens. But I stand corrected. But it's usually in the form of the really young ones have got the potential for anaphylaxis, and the parents have got EpiPens. But they're not getting desensitization. They're getting avoidance of various substances, and they're getting steroids. But at the same time, I remember one kid in particular who was 12 and had 2 years of desensitization, doses of oral cortisone, steroid sprays for 5 years, and he had these massive turbinates that needed a powered reductive turbinoplasty to actually get him to breathe. So you can throw lots of medicines at people, but sometimes they need treatment by surgery, just as there are cases that Simon alluded to that have got such severe orthodontic problems that they need a fascia max guy come in. That's not to say that they don't need orthodontics, they do, but they need to have that treatment armamentarium widened.
All right, terrific. There's a few more questions that have come through, so let's move on. Thanks, Cindy. Thanks, Perry. Another question for Perry. Judith asks, I've seen babies who are still so young, 4 months or so, and have their mouth open when sleeping already. What's your thoughts on this?
4 months. That's incredibly young. I don't treat kids under the age of about 8 or 9 months, so they tend not to come to me. The kids that are that bad, I can say that the youngest tonsillectomy I've ever done was 14 months. I told the parents that the kid either needed a tracheostomy or a tonsillectomy. I do know that the now retired head of ENT, the children, said the youngest he did a tonsillectomy on was a kid who was 4 months. But that's one case in 35 years of practice. So I think that they're the complete outliers. Most of the kids who have got major breathing problems at that age have usually got laryngotracheal breathing problems. So they've usually got some sort of anatomical or functional laryngeal problem. So they're the kids that are actually in stridor, as opposed to sturt or oropharyngeal problems. Again, the Children's Hospital get the craniofacially anomalous kids, and that's a completely different situation. The syndromic craniofacial kids, the Pierre Robin type kids. But if we're talking about a normal kid, most of those, usually don't present so much with mouth breathing. Most of them will present with ear infections. because their adenoids are usually big, and that causes the eustachian tube dysfunction. So that's usually the two issues are really more ear infections and feeding problems, often from frenulum issues. And again, mouth breathing itself, whilst uncomfortable, isn't really a major medical problem in a neonate or a youngster. The other thing that I would also be concerned about is, have they got some sort of choanal atresia or stenosis? That'd be something that I'd also be concerned about, that needed excluding.
Terrific. Marielle has a question.
Unless they've got apnea and protracted apnea, then I think, like Maslow's hierarchy of needs, you have to stratify what the problem is and how much you want to be active in treating it. And generally speaking, I operate on kids over the age of 1. I've done lots of grommets in kids that are sort of 8 or 9 months, where the kids are just plagued by ear infections. Done adenoids from the age of sort of 11 months upwards, but again, it's usually, that's not the major feature of the problem at that age.
Okay, there's a few more questions. Let's go through as quickly as we can. Another question from Mariola. I have many children with allergies blocking their noses. Where can I refer them to find out what kind of allergies do they have and how to manage these allergies? Yeah,
so again, there are pediatric allergists. There's a lot more of them now than there was 20 years ago when I went into practice. But there's a whole group of allergists. I know there's a group at the Epworth, and there's also MACS, MACCS, in near the Royal Children's in Melbourne. So, and there's a few scattered around metropolitan Melbourne that I also refer to, and they've almost universally been very, very good. And so I've got a number of people that I refer to. So that's who I would go to if I was seriously concerned about a major allergic problem. And most of those kids have already been trialled on some sort of steroid. But again, you've got to have a kid who's compliant with it and it's being used in an appropriate manner.
Okay,
Thank you very much, Perry. Yeah.
Terrific. I think a final question for Perry, and any questions for Roland, Max Fax surgeon. So a question from Judith again. Hi, Perry. I've heard tonsils being described as they've grown back. Is this incomplete removal, or is it meant to regrow to an extent? That's a good question.
It's a very good question. And, we only ever want perfect results when we operate. The problem is that anatomy is imperfect. So firstly, when we do a tonsillectomy, we're taking out what are known as the palatine tonsils. So they're the tonsils that you can see when you open your mouth. But there are also lingual tonsils. So there's some lymphoid tissue at the very base of the tongue. And the problem with going too deeply is that we can A, get massive hemorrhage if we go right into the tongue base, and B, you can interfere with taste sensations if we go too deeply. So there's no dotted line as to where to go, and as I said to the group last week, surgery is like operating. Is like trying to get a view near a cliff. You stand back and you don't see anything, and you go too far and you're over the edge. If we don't take enough out, they regrow. And if we go and do too much and go too far, we get often some massive bleeding problems. So the other thing is that there are also, just as if you look in the mouth and the posterior pharyngeal wall have those scattered little ectopic bits of lymphoid tissue, so you can have that in the tonsillar fossa themselves. And so if we, again, this is what I tell patients, that if you're trying to take a weed out of a garden and you grab most of it, you're probably going to be okay and it won't grow. But there may be some little roots at the very base. Now, if you wanted 100% remove every one of those roots, you'd be taking this massive divot out of the garden and you'd have a huge hole that you can fall into and hurt yourself. So there is a judgment call as to how deep we go, notwithstanding the fact that there are little bits of ectopic tissue. So generally speaking, they're not of major concern, but sometimes they can be clinically relevant, and we do have to go back and remove a bit more. As I said last week, there's a range of things that we can do to the airway, starting with adenoids, tonsils, various minor things to the nose, various moderate and more significant things. And a lot of these patients, I'm doing sequential treatment at an age-appropriate time. And so if we have to do more, say, to their nose, and there is some lingual tonsil tissue there, then I'll often advocate that we'll just trim that at the same time. But the reality is that you can, if you look hard enough, you will see a little bit of lingual tissue there, but it's usually not majorly significant. But we mark ourselves down. If you look at that, you have to say, well, I didn't do quite as good a procedure as I may have hoped.
Terrific. Thank you so much, Perry. So we've got another 15 minutes. Any questions for Roland?
So one of the things that Roland will also be helping those who are based in Melbourne is that I believe Roland is going to assist with dome expansion. So the TAD assisted expansion for older patients that follows the Stanley Liu and Audrey Yun methodology. So if anyone has questions on that, Roland can help with that as well.
Roland, while people are thinking of some questions, you want to kind of introduce yourself and how you guys met and what your specialty is, I guess.
As we're talking about a couple of Q&As ago, I met Simon at the Integration Obstructive Sleep Apnea meeting in Melbourne. Yeah, so my interest, really piqued my interest with airway and looking at how the craniofacial morphology can affect that. And the role of interdisciplinary management coming into place as well. So, yeah.
So I think Roland is going to, if you guys wanted to do older expansion, maxillary expansion, Roland can assist with the dome technique and also work with our lab to place the implants in for you and have everything set up too, so that it's something that, if you need help with the full range of the treatment. And some dentists will ask the surgeons to place the TADs and then they'll build the restorative component on. But I believe that, we can organize everything depending on your level of skills.
What sort of, have you had much experience with the dome appliances? Like the palatal borne, many implants.
It's a relatively new process using a method that is historically quite has been used for a very long time. So in the past, we've anchored the expander onto the teeth, and in our case, we anchor it into the plates. But recently, the orthodontists have been asking surgeons to help them out by putting them into the palate itself, so bone-borne anchorage, the last 10 years. And the most recent of the published techniques is Stanley Liu, and Wan Moon is the other one, who's also been published recently. So these are more for adult patients, and I don't treat many adults, so personally I don't have much experience, but conceptually it's the same process that we've always used. It is designed for a rapid palatal expansion, so you break the suture, yeah, you have to have some experience before you set about.
The advantage, of course, being that it's distraction osteogenesis, so you're getting new bone apposition as opposed to dental movement, which can be an issue moving the teeth out of the alveolar envelope.
Yeah.
Also has from the airway perspective, from the internal nasal valve, it opens things up a bit, I believe, Perry. Can be an advantage with that from the upper airway perspective. Yeah.
So lots of, for the older patient that's outside of our remit, or my practice, and many of you will have orthodontic patients who are adults or teenagers, and those ones you'll struggle to get good expansion, and you'll end up with just tipping teeth out. Whereas if you want to start to operate in this spectrum of patients who have obstructive sleep apnea, or certainly at the mild and moderate level, then Roland can assist. And we now know with Stanley Liu's technique and his protocol that it's a good first step. So even if you do need orthodontic surgery, closing rotation, and MMA advancement, this is a better way of doing it by first doing the palatal expansion and then moving the maxilla in one unit rather than doing a three-part, which is what historically we've done, and creates a good orthodontic result but a terrible sleep result.
It's also a lot more technically challenging to do it all in one go. So a three-piece maxilla combined with biomaxillary surgery. So doing the expansion beforehand and then proceeding to a biomaxillary surgery with counterclockwise rotation to really lengthen the mandible and open up the airway.
So not every surgeon understands that you can't get really good results with sleep breathing surgery if you do a three-part. And none of us really understood it until Stanley explained it to us, that you leave the soft palate where it is. If you do a three-part, you're leaving the oropharynx untouched, effectively. And that's the big bottleneck for obstructive sleep apnea. But if you do the dome technique first, not only do you get the nose into the floor of the nose into the better place and the nasal valve opening up, but you have the opportunity to tent forward the oral pharynx, which is really the major bottleneck for sleep disorder breathing.
Okay, I got a question from Stuart. For Roland, can you please give a ballpark figure on costs and timelines for surgery, maxillary advancement, mandibular advancement, both, as well as maxillary expansion?
Maxillary expansion, about 1,800 with the dome procedure. And then with bimaxillary surgery, about 7.5. Single jaw surgery would be about 4,000 ballpark. For mandibular advancement. Yeah.
Terrific. Alrighty, any other questions for Roland? Otherwise, we'll circle back. Okay, another question. Roland, how is COVID-19 affecting your practice now and into the future?
Yeah, it's having quite a major effect on operating lists and things. Currently, I'm only working publicly on Category 1 patients. That's on the major head and neck cancer oncology cases. My practice has been restricted to basically more emergent treatments like toothaches and things like that. Early infections that can potentially get worse. And certainly at the Austin, we've seen a spike in odontogenic infections, which have become more severe recently because patients aren't able to see their dentist in a timely fashion. So it's been a really trying time, but we're able to still carry out more urgent procedures under local anaesthetic with the full PPE. We've got a pretty good setup in Armidale, very spacious with good ventilation. So that's helped with being able to help our referrers out in the short term. Yeah.
Simon, can I ask Roland a question?
Sure.
Yes.
Can I just ask you, do you do much in the way of genioplasty procedures alone, or are they usually a more advancement or Biomax procedure?
More so mandibular advancement surgery. With a genioplasty, it can often be a compromise with both aesthetics and the airway. I know that there's some sort of suspension of the hyoid, the digastrics and the suprahyoid musculature as well. But generally speaking, we'll try and work with an orthodontist with decompensation of the dentition. So say in a class 2 patient, try and rein in those low incisors and get the maximum advancement. Even if that means in some cases removing lower premolars, you end up with a good occlusion at the end. And the lower sixes would be in a more anterior position, like a class 3, but with a good occlusion and longer mandible as a result. Yeah. So generally speaking, don't do them isolated as much as say with a cosmetic rhinoplasty indication with those class 2s. Certainly from a functional perspective as well, it's better to do a sagittal split osteotomy, moving things forward. And if there's anything to address the lip competence, a genioplasty can be done to advance that as well.
And the other question I have is, and it's for Roland and for Simon, is you see some kids and they're really quite severely class 2, and they're getting various orthodontic expansion. What do you do to sort of counsel them that to get a better and an even better result aesthetically and functionally, that they're going to require orthodontic surgery, and this is a stepping stone to that? And is it also better for you, Roland, to perhaps have to advance someone 6 millimeters rather than 15 millimeters?
Absolutely. Yeah, a lot of that has to do with the stability of the movement as well. So,
I think historically, orthodontic surgery, you want to keep within an 8 millimeter movement range, isn't it, for it to be safe? But Stanley Liu is doing 25 mil movements. But everyone has a different approach depending on whether they're doing counterclockwise rotation, mandibular, significant advancements, and what they're doing it for. So if you're doing it for cosmetics, which orthodontics tends to be, you have a different guideline to if you're trying to correct obstructive sleep apnea. So it really makes a difference why you're doing it, doesn't it? And the tools that you use. And I think having the dome technique allows you to do different procedures at a higher level with more safety than you would if you were doing a 3-part and doing a split sagittal on the lower. That gives you a much different range of safety limitations. And so, the techniques that we've been learning today allow us to do a lot more than we've done in the past. Would that be true, Roland?
Yes. Yeah. There still is a role for segmental surgery as well, but certainly from a technical point of view, it's much more straightforward to do single maxilla and mandible. But the other thing to take into consideration is also the patients might be getting a bit burnt out by the time you starting to talk about biomaxillary surgery on top of a dome and the other treatments as well.
Yeah, so that's up to the first person in the setup, which is usually the dentist or the orthodontist, to make the right decision and treat a skeletal problem skeletally rather than try to band-aid a skeletal problem with orthodontic attempts. Because if you have a patient 5 or 6 years in treatment and then realize at the end of it you should have done surgery in the first place, then you're not in a good place. But if you have planned it from the beginning, then you're in a different situation. Perry's question as to, they're having expansion, but then how do you tell them that it's only part one of a multi-part therapy? Well, the reality is it's up to the person who begins that treatment to explain to the patient, you have a skeletal problem. My expansion is going to help you in the transverse dimension, but you're going to get nothing in the AP and I'm not going to be able to control the height. If you expand in a patient that is compromised in its transverse only, then, Bob's your uncle and everything is hunky-dory and life is wonderful. But if you've got a major skeletal imbalance, you have a major class 2 with a significant divergence in their growth pattern, then expanding will fix one of the 3 or 4 problems that you're dealing with. And if you've left that as a surprise for the patient at the end of it, then no one else will be able to manage it for you. See, Perry can't talk about this if the patient hasn't been pre-qualified to understand that this is one part of a 4-part process or whatever. And how you, Perry, would be able to have this discussion with parents is this. You say, look, I don't understand the exact processes involved in orthodontics, but from a surgeon's perspective, the face is 3 dimensions. There's width, there's depth, and there's height. I know this expander deals with the width. How is your orthodontist helping you with the depth and the height? That's all you have to say.
And do you think you get any anterior movement with the expanders, Simon?
Well, you can, but it's measured in 2 or 3 or 1 or 2 millimeters.
Right.
Yeah. So in a mild or moderate case, you might get an improvement, assuming they keep their mouth closed. But if they don't keep their mouth closed for nose not working, the airway blocked, or because no one's told them to keep their mouth closed, then just expanding in a very young child will get you maybe 2 or 3 millimeters. In an older child will get you 1 millimeter. In an adult will get you nothing. So the tool does this. But if you have this and this issue, then you must have a plan for that. Otherwise, people like yourself are going to say, oh, that's fantastic, you've got this, what's next? And then if the patients have a blank stare, what do you mean what's next? It means that whoever's doing this hasn't really considered the full picture, and all they've done is put a tool that they've got in the toolbox into play. And that makes it really difficult for everyone. And that's why, this is the reason why I'm teaching. To teach people that your one tool only does the one thing. And you actually have width, depth, height, and age to deal with. And if you're working with 4 problems, sometimes you have to ring up Roland and say, I need you. And then you ring up Perry and I say, but I might need you first.
I mean, I was going to say, I do very much the same when it comes to sleep apnea, is that I emphasize the multi-level nature of the problem, and that we're going to be addressing this one level at a time, but that you need to be fully cognizant that it requires that entire pipe being right for an optimal result. Can I just also make just a quick comment on the nasal valves? You mentioned about the internal nasal valve earlier on. The internal nasal valve is at the area at the top of the nose. So you know how the cyclists sometimes wear those strips that go over the nose to expand the mid part of the nose? That's the internal valve. At the base of the nose, which is where dome is going to be affecting it, that's going to be more what we call the external valve. So it's more the apertures and the floor of the nose, which is where most of the airway takes place. But the perception of nasal congestion takes place at the top of the nose, and especially in patients who've got long, thin, projected noses, they're the ones that get nasal valve collapse, and there are various treatments that we can do surgically for that. But that's another.
What do you believe is like a really good treatment to address that? Would that be like spreader grafts and that?
Yeah, so there's been an explosion of regimens to try and deal with that. There's some controversy about spreader grafts in that most people, so again, we're going a little bit off topic here, Simon, I apologise, but when you take down a dorsal hump, the upper lateral cartilages just prolapse inwards. And so the old style rhinoplasties that looked very, very pinched at the mid part of the nose, a bit like the Michelle Pfeiffer noses, they've had the internal valve disrupted, and they need spreader grafts. And there are various types. There's 5 different types. There's also a technique, what we call spreader flaps, where we fold the cartilages in. And for the external valve, there are various crural inlay strut graft, tensioning, extended rim grafts, etc. But we can talk about that at another time on functional nasal surgery. But what my dental colleagues need to really understand is that there are, when it comes to nasal congestion, you've got septal problems, you've got turbinate problems, and you've got the tendency for the nose to collapse inwards, and that's either at the internal valve, the mid part of the nose, or the external valve right at the very front. So, but yeah, spreader grafts are an integral tool and a workhorse of the functional valvular reconstruction.
Thank you, Perry. Thank you, Roland. So there's definitely a whole there's a whole 2 disciplines of specialties out there that most of us actually have no idea about. And one of the reasons why in the upcoming courses, I want to have at least an introduction from these 2 specialists on what treatments are available to make our lives manageable. All right, so, you know, and then what can we do to help the children in a way that is going to best serve them by referring to the ENT specialists and the MaxFac specialists, because we underutilize them, because we don't know enough about it. So we need to learn more so that we can use them appropriately. And I'm hoping that in the advanced course that Roland and Perry will join us and answer all these pressing questions that we don't even know we're supposed to be asking. So I'm going to.
Can I also say that also I'd advocate that a sleep physician is also another crucial member as the 4th pillar.
And I might have a chat with you about who you might recommend that we introduce into the forum later too, because you know, we use different people, but obviously it's better for us to use someone that you use all the time, so that there's that harmonious interplay that only comes when you've been working with someone for a while.
Yeah, I think that's integral. For the really young kids that are very, very obstructed, and also for, I'm sure a lot of your attendees also fit mandibular advancement splints, and I think that really sinks in well with the entire sleep assessment and management of obstructive sleep apnea.
Yeah, absolutely. So hopefully I'll be able to speak with you and work out a game plan to who can participate and who can give the very valuable input. So speaking about the advanced course, I might put us back to Kian, who talk a little bit about wrapping up this session, which is the last of the introduction sessions, and talk a little bit about what comes next. So thank you, Perry, and thank you, Roland, for your input. And I know that based on the number of questions that are starting to be fired in, that we'll probably need you in that next session ahead.
Thanks for having me.
Now, we will, in the meantime, because there'll be still a little bit of time ahead before the next sessions roll through, is we'll make sure that all the attendees get the contact details for Perry and Roland, if that's okay with you guys, so that they can communicate and start to use you guys for patient referrals and that kind of stuff as well.
And also, if you need, if there are interstate people, I can recommend interstate people as well that are very au fait in this field as well.
Terrific. Thank you guys so much. Roland and Perry, do you mind just sharing your email in the group chat in case there's some people with half a dozen questions that have come through? Unfortunately, we've kind of run out of time. So you can direct the questions personally to Perry and Roland. So thank you again, guys. And I'm sure you'll join us for other advanced sessions. So at this stage, for those of you who want to stay around and ask questions about the advanced course, please we'll stay for an extra 10-15 minutes. If you need to head off for lunch and wrap it up, thank you all for joining us for the whole 2-day event plus these 3 Q&A sessions. Hopefully it's been of value. I've certainly learned a few things about what my brother does, but hopefully it's very useful for you guys. So Roland Barrowman, thank you for your email, barrowman@me.com, and Perry, if you could just type your email in the group chat, that would be true.
I'm not sure.
Or maybe
I'm a bit computer illiterate, so.
Actually, I've got it. Sorry, let me.
Okay.
Yes, sorry about that. I've got it here right in front of me. I'll quickly submit that.
Thanks very much.
Oh, I sent it to the wrong person. Let me send it to everyone. So Perry is it CALAN, Callan, D for David, Perry, a Big Pond.
Yeah, it's Cal. My wife's Caroline, so her nickname's Cal, so it's Callan Perry at Big Pond.
Sorry, thank you.
Yeah.
All right, terrific. That's I guess.
And Perry, your wife is a infectious disease specialist at the Royal Melbourne, right?
She is. So she's been coordinating. She's head of infection control at Royal Melbourne, where they've been obviously, trying to contend with the potential pandemic influx, and very pleased that things have headed in the direction we hoped. And having been in contact with a few of my colleagues in Europe and North America, they've got a vastly different experience, which is far more problematic. So I'm happy to. Basically, I get updates from my wife as to what's going on and the state of play on the ground.
Yeah, glad to hear things aren't as bad as in New York and other places. So terrific. All right, thanks again, guys. So let's open up to questions. There's still about 20 of you guys here, so I'm sure if you want to stay around and ask questions about the advanced course, I'll open up to questions.